Let's talk now about some more dental office medical emergencies. I've called the lectures Anesthesia Medical Emergencies in the Dental Office, but you should know that it can be in a medical office anywhere that you're working. And as I said, there's a lot of different environments where you can bring your knowledge and skills in to help or to just take care of the patient straight off if you find a patient collapsed or something in a venue or wherever you are shopping, as we talked about in the first lecture. We saw that we had the 13 different emergencies, and we've gotten to number 5, cardiopulmonary arrest. I want to go through the rest of them with you. Allergic reaction to drugs, angina pectoris, possible MI, emesis, aspiration, possibly of vomit, convulsions and seizures, oversedation, hypoglycemia, asthma, bronchospasm, and respiratory depression. Allergic reaction to anesthesia medications is pretty rare. With any of the stuff that we normally use for a patient, I've seen the opioids are really the only reaction, some of the pill form opioids, but a lot of times it's going to be with antibiotics. You can see amoxicillin down on the bottom. Sometimes we're giving cefazolin to a patient for infection, but there's a few people that will react to that. That's why obtaining a good medical history is needed. But drugs like lidocaine, midazolam or Versed, fentanyl are extremely rare. I've heard patients say that their heart rate went up with lidocaine, and it's not a reaction to it. As you know, it's probably if there's vasoconstrictor in there and there was an intravascular injection of the local anesthetic. Any true allergic reaction is life-threatening and is disastrous for the patient, and we've got to really quick recognize and get on treatment for these patients. So some of the signs and symptoms of an acute allergic reaction, there's going to be rash. This is from the rapid outpouring we'll see of histamine especially. They're going to get rapid edema, lip swelling, tongue swelling, airway swelling. This could be a disastrous airway emergency. They're going to get bronchoconstriction due to secretions that occur from the allergic response, upper airway obstruction, and if it's a severe, true anaphylactic reaction, they're going to die before they hit the floor. But a lot of times, they're not as severe as what we've seen here. They're going to get itching of their skin. They're going to have acute, rapid hypotension, dropping of their blood pressure. So physiologically, what's going on in these patients is they have seen this allergen, this thing that stimulated the allergy before. And it can be any of a number of things. It can be skin contact with the substance, animal dander, poisonous plants, pollen, latex back when we were using that, the powder inside latex gloves, a bee sting. Certain medications. People have had hand lotions that they've used, they've been exposed to, and I've seen them break out from that. It could be a medication that they're taking and that they have taken, and all of a sudden they will develop an allergic reaction to it. It can be a reaction to a medication or nuts and shellfish. Again, pollens, dust, mold, mildew, animal dander that they inhale. So that goes down deep into their respiratory tract. The cause of this release is going to be from an antibody-antigen reaction. The chief antibody that causes this is going to be IgE or immunoglobulin E, and it's produced by the B lymphocytes. So the antibody is from B lymphocytes. And you can see it's shaped kind of like a noose with two stems that come out of the molecule. And these stems are what is going to attach to the pollen, to the dander, to whatever's causing the allergic reaction, that are attached to two different types of cells that are in our immunological system where the B lymphocytes are located. So that B antibody is going to attach to the antigen. And we've got two different places where these antibodies are located. Mast cells are going to be within our connective tissue, and basophils are circulating, kind of keeping guard through our circulatory system, through our bloodstream. You can see the picture of the mast cell and all those granules that are there, and they have antibody attached to them. So mast cells and basophils that are circulating are present. Mast cells are in the connective tissue, basophils are circulating. And some of the nasty chemicals, and there's a lot of them, that are produced whenever the lymphocyte is stimulated is the release of histamine, which is going to cause our itching, all the bad things we saw with an allergic response. Serotonin, bradykinin, and heparin are released. And again, allergic reactions, especially anaphylactic reactions, are going to be really rare. So in order to respond to a true allergic reaction, we're going to want to turn off nitrous oxide. We're going to want to turn up oxygen. We're going to want to make sure we have our CABDs. We're going to have albuterol ready in case they're not breathing. We're going to want to open up their IV fluids so that we can get drugs into the patient. The first drug that we're going to want to give the patient is, again, your epinephrine, like what we saw with cardiac arrest. That's the most important drug. Secondly, we're going to want to give an antihistamine, and this is going to be for an acute allergic reaction. If we've got a patient that's just broken out itching, we can skip the epinephrine unless it's severe. What's going on with the patient is severe, and go straight to the Benadryl, the diphenhydramine. One of the other drugs that we use is famotidine. It is also an antihistamine like diphenhydramine is. The diphenhydramine is going to be circulating again from the mast cells and the basophils. The famotidine is going to treat histamine. It's an antihistamine that is treated and released from the GI tract. And the last thing we're going to want to give the patient is hydrocortisone, which you've got in your emergency drug kit. If you've got dexamethasone, which is an excellent steroid for treating nausea and vomiting, especially nausea, or methylprednisolone, which is another steroid. So this is what those drugs look like: the ampule of epinephrine, methylprednisolone, famotidine, diphenhydramine, hydrocortisone. EpiPens are just so expensive. You can have a syringe ready with a needle and just buy epinephrine vials. So the goals are to counteract the massive release of histamine and all those nasty chemicals we talked about. We've got to reestablish blood pressure and maintain the CABDs. If things are bad, we're going to want to call 911. I have treated urgent allergic responses and monitored the patient by giving diphenhydramine. The blood pressure was not bad. The patient was monitored, and we just kept an eye on the patient until the allergic response was reestablished so that we've got stability in the patient. You can see me holding a vial of Sayucortef, and you'll be able to see how to mix one of these vials up. This is just the way the drug has come, and it has always been that way. So you should know how to activate one of these vials, where you go to pop the top off and draw the med out with a needle and a syringe. Here's your doses for epi, diphenhydramine, famotidine, and Sayucortef. Methylprednisolone. We used to use the drug ranitidine, which is Zantac, and that was taken off the market because it causes cancer. So if you've got any Zantac, which if you do, it should be expired by this point in time, toss it. Toss it in the trash because it's just not used anymore in the emergency algorithm. Let's talk now about angina pectoris, possible MI, myocardial infarction. So the word angina is from the Latin word meaning angere, which means to strangle. It's a severe crushing pain, and it differs for men and for women. It can differ. It's been described as having an elephant, like an elephant sitting on your chest. It's so crushing, which is a sign of the heart muscle just not receiving enough oxygen and causing quite a bit of pain. So heart muscle is dying when that crushing chest pain is felt. So we've got some main coronary arteries. The left anterior descending is also called the widowmaker, and then there's the right coronary artery. And the heart receives its oxygen supply, its arterial blood, during diastole. So in a person with some amount of heart disease, if the heart is beating too quickly, the heart won't have time to fill and bring enough oxygen, especially if there's coronary artery disease, to the heart muscle. And that's when heart muscle can die, or if the vessels just clog up with plaque. We see here the lumen of a normal artery. You can see it's still kind of got some rough edges around the middle, but it is totally and widely open. Then we start to develop a fatty streak along that lining, and that is the beginning of the coronary artery disease. As we progress further, we see that it is called now an atheroma, and it's just from the plaque, the cardiac lipids that are coming to the tissue and just laying layer upon layer and occluding the lumen till eventually to the point where it's going to be totally closed. We see then that it becomes fibrous. There's a fibrous plaque. Look at the size of the lumen in the fibrous plaque compared to the normal coronary artery. It just doesn't have enough blood flow to it. Blood's going to really have a tough time getting through. And then with total blockage, the blood clots. When blood stagnates, blood clots. So that clot occurs and there's no flow, and that is when we have that golden hour. We have got to get the patient into the cardiac cath lab to have that coronary artery reopened, or that heart muscle is going to die, and there's a good chance that the patient's going to die. So let's look at the difference in anginal symptoms between men and women. With men, the description is seen as chest pressure, crushing chest pain, like we said, the elephant sitting on the chest. There's sweating or diaphoresis, a heaviness in the chest, tightness in the chest, fullness, squeezing, and then with that is severe anxiety when you know pretty much that you've got some problems with your heart, your body's pump. Less often, there may be complaints of knife-like, sharp, or stabbing pain, not quite as often as the other symptoms that we talked about. With women, symptoms can differ. It may produce unusual fatigue, sleep disturbance, shortness of breath, indigestion, and anxiety. My feeling is that women are a lot more used to pain than men. I'm not saying all, but just overall. And these symptoms don't seem as bad, if you will, as a crushing, debilitating chest pain that men feel. You can see that there's other things in women that can cause those same disturbances. If you're using an EKG, you will see either an ST elevation. Notice it's not coming down to the baseline, the isoelectric line that's called. So it's elevated, or there's ST depression. So we go from that QRS tracing and we see it's down below the isoelectric line. And remember that anybody can experience this. It can occur in any place in the office, so we have to be able to treat those patients. There's stress while you're waiting for your appointment. Could be a family member, just anything. While preparing for sedation, those are stressful times for the patient. While beginning the sedation with the IV stick, starting the meds, and even while preparing for discharge. So the steps to take are we've got to get oxygen to the tissue and we've got to get it there quick. Once the pain has started and the patient is suffering, we've got to get oxygen to the tissue. So we would call 911, tell them that we've got a patient with angina, possible MI, and that they will get there as quickly as possible. If you've got morphine to help treat the pain, that would be a great thing. A lot of dental offices don't carry morphine, but you do have fentanyl. So the fentanyl for that crushing pain and all those symptoms that we saw earlier will really help. The good thing with morphine is that it dilated in a small amount the coronary arteries. Have them chew a baby aspirin or swallow a baby aspirin. You'll carry those in your drug kit, and they probably are chewable since they're baby aspirins. They're only 81 milligrams. If the chest pain is crushing, we're going to want to use sublingual, below the tongue nitroglycerin. It's going to open up their coronary veins and their coronary arteries to a lesser extent, but it's going to really open up their veins in their head and they're going to get a severe throbbing headache. Recline the patient, they're breathing oxygen, don't stress them, keep them comfortable, get a cold washcloth to their head until 911 gets there. Then we have the pictures of the morphine. You've seen a vial of fentanyl, and then there's 81 milligram chewable baby aspirin and the nitroglycerin tablets. They're little tiny white tablets that you put under the tongue and they dissolve very, very quickly. And they also have it as a spray that you spray underneath the tongue. And don't forget the oxygen. We talked about morphine a little bit earlier. So we use the morphine, as we said, because it can dilate to a small extent the arterioles, especially the coronary arteries in this case. Baby aspirin will cause inhibition of the platelets, so that any more clot from forming because of the stagnation of blood. And then the nitroglycerin that will increase venous blood flow to the coronary arteries and open up the coronary arteries and the coronary veins, more so the veins, as we said. An IV needs to get started if you don't already have one. So the main goals are to calm the patient, get them to breathe pure oxygen, slow their breathing down, take big deep breaths, administer to their pain, use the meds as necessary. I've had patients with chest pain, and it sounded to me more like that it was just from eliciting a diagnosis from them as more of a hunger pain. So we did not use sublingual nitroglycerin, but don't hesitate to use it if need be. So you've got to really ask the patient the proper questions, and those are just to keep inquiring until you've got a firm idea of what they're sensing. Here's the dose for morphine. Again, these are just suggested doses. It's going to be based on the patient. These are just put there for your information. Same with the aspirin. If they were to take a full aspirin, baby aspirin, as we said, is 81 milligrams. And the nitroglycerin, 0.4 milligrams sublingual. And it can be given every 5 minutes. I refer you to the Lexicon Pharmacology book. It's a big, thick paperback book, and it's really got the information you need with the most current things that pharmacists are saying. So again, it's Lexi, Lexi-comp, C-O-M-P, pharmacology book. Big, thick, yellow, orange, whatever their color is for that year. All right, let's talk about emesis and aspiration of vomit. So what can precipitate nausea and vomiting? Patients don't tell us the truth, so if there's food in the patient's stomach, that can lead to nausea and vomiting. Dehydration, as we talked about earlier, can cause it. Anxiety and stress. certain oral or intravenous meds, and we're talking about opioids here, can produce nausea. The smells in the dental office, and just the fact if they're dizzy, off balance, or lightheaded. So before you start any case, you make sure and document what the patient's NPO status is. And this slide or this picture will show you the most current, up-to-date rule that we follow. It's not a law, it's a rule, but it's 2 hours for clear liquids. If it's non-human milk, it's 6 hours. A light meal consists of something like maybe a hard-boiled egg, unbuttered dry toast, just some black coffee, no milk in there, and that's 6 hours. And then a heavy meal is just a regular fatty large meal. So we've got to go at least 8 hours to be able to treat the patient. And I can tell you that since this is just a way that we practice in anesthesia, that this is what you want to follow and make sure you document it. We've got that patient preoperative assessment we've talked about in other lectures, and it's available to you through the sedationconsult.com website. Look for forms and you'll see all the forms I use there. And we have a new way, just to show you that we keep up with technology. I don't expect the dental office to have this, but there's something called POCUS, which is called point of care ultrasound. So some of these can be hooked up to a smartphone or a screen, and you've got an ultrasound probe, and you can actually look to see if there's food or liquid in the stomach. So this is real new now, and the technology is quite expensive. It's probably costing well over 5 figures for something like this. So if the patient starts to experience nausea, open up their IV, have another bag ready to go. Some of the anti-nausea medicines that are in your emergency drug kit are dexamethasone. If the patient can have steroid, it's a potent antiemetic, and you can give them 8 to 10 milligrams. It usually comes 4 milligrams per milliliter. There's ondansetron 4 milligrams or dilasetron, which isn't as common. Ondansetron's been a generic drug for a long while, so the cost is much better. Then there's Reglan or metoclopramide, which stimulates the GI tract to move along, and it increases and stimulates peristalsis. As a rescue thing, there's inhaled vapor of isopropyl alcohol. So if you tear open some of your alcohol wipes and put that under the patient's nose and have them take a couple deep breaths, it's going to help them with their immediate nausea that they're experiencing. And way in advance, this is going to have to be before the patient even comes into the office, you can prescribe a scopolamine patch that the patient would have to pick up a prescription for. They're 1.5 milligrams. They look like a small circle. It looks like a small bandage, and you put it behind the ear where the skin is behind the ear. You're just opposite the earlobe. But you have to do it way in advance, as I said, and it can cause some dizziness and some bad feelings for the patient too. But it's something we use for patients when they just say, I just throw up, say at the drop of a hat. So you want to give them something way in advance. So that's something that you can do. They don't want to scratch their eyes once they've touched that pad. They're going to want to put it on their skin after they maybe cleaned it with a wet washcloth and dried it, or an alcohol wipe. Make sure the alcohol's evaporated. Put the patch on, wash their hands. Scopolamine is related in the same family. It's a belladonna alkaloid like atropine is. So if the patient does begin to vomit and they'll start to make movements with their stomach and you'll hear sounds, you're going to want to elevate their head quickly and turn their head to the left because of the shape of the bronchi, the main stem bronchi. Get the emesis basin, have suction ready. If you're working with an oral surgeon, the oral surgeons have the patient turn the patient's head to the right if they're starting to vomit. So just telling you that it's different from what we use in the anesthesia profession. So if you look at the bronchi, you can see that there's the main stem bronchus that's there. The right really goes down even more steeply than this picture, and the left kind of goes out at more of an oblique angle. So any of the vomit will travel down. Hopefully it's not going to go into the lung and cause aspiration, which can lead to really severe pneumonia and a 911 visit to the hospital if aspiration occurs. So hopefully, if they're not too deeply sedated, they're going to start coughing anytime something goes down that delicate airway. And you can see on this photo how the right just drops right down into the depths or in the black, and the left is coming off, like we said, an oblique angle. That split and that tissue that's there is called the carina, C-A-R-I-N-A, and it is extremely sensitive to anything touching it, and it will stimulate a really strong cough reflex. And here's just another picture of the right stem, main stem, and the left main stem bronchi off the main bronchi. So the left bronchus and the right. Here's just another picture showing the steepness then of this anatomy of the trachea as it goes straight down into the right. So the whole idea is to elevate the patient's head so that they can hopefully cough and spit it out, and you can suction out any of the substance that's produced. Get their head to the left, right side if you're working with an oral surgeon. Get the emesis basin, get your low and your high-speed suctions out, and just suck all you can out of the mouth and down the throat as far as you can. So again, when you're using the high-speed suction, you're going to want to really get to the depths of their throat. And here's a picture of getting the Yankauer. I would go even further in back of the tongue. You see the mannequin there and the plastic Yankauer. I would really use the anatomy of the Yankauer. You see the one, the reusable one that's on the right, but just get all the way down the throat. If they're gagging, that's fine. If they can, we just want to get everything out of their throat. And there's your dose of dexamethasone, ondansetron, metoclopramide, and there's showing you where the scopolamine patch goes. Let's talk about convulsions and seizures. We're starting to get into some of the emergencies now that are pretty rare, but you still have to know how to treat them. I have had this happen to a patient that I was teaching in an anesthesia lab, teaching IV sedation, and the person went into grand mal seizures in one of the other operatories. So we're going to want to turn the nitrous off. If they're breathing nitrous and they go into a seizure, you don't have to turn the oxygen on. You can just, as quickly and safely as possible without hurting their eyes, pull the whole mask off so that they don't cut their cornea or get tangled up in the tubing of the nitrous mask and the hoses. If the patient's in the chair, position them flat, or if they're on the floor, get them to the floor and guard them so that they don't get poked by anything, bump into anything while they're experiencing their seizure. This is a call 911 emergency. And remember, like with this, any of the emergencies that we have to call 911, you've got to submit a written report to the board. We would use midazolam or diazepam and draw up 2 vials quickly as possible, get that in under the IV, and start to break that seizure. The patient experiencing tone or tonic is when the muscles are contracted and they arch and they can go into some really stiff muscular positions. Clonic is when the muscles relax. This can be broken. It breaks real well with diazepam and midazolam. And we're going to be talking about this in one of your other lectures, but we've got to be careful using this in the pregnant patient. And we will touch on that when you're doing your dental office medical emergencies lecture. A little bit later on, we're going to be going through emergency medications every dentist should know. And don't forget, since we've got benzodiazepines here, you can see the 2 bottles, you're going to be producing some pretty heavy sedation on the patient. So you've got to be able to have your bag mask valve there to breathe for the patient if necessary. You can see that with the benzodiazepine half-life chart that midazolam has got a short half-life compared to diazepam. When diazepam is metabolized, it's metabolized to nordiazepam, and it is as active as diazepam before it's even metabolized. So the idea of these graphs, these cone graphs, shows you that you may have to redose the patient because of their half-life, especially till 911 gets there. So be prepared for that. If you want to carry diazepam in your office, hopefully the chances are that it's going to expire and that you're going to need to buy a new bottle. But it's really a nice treatment for anxiety as well as for a patient that's seizing. So look at their half-life. I wrote a chart here showing benzodiazepine half-lives, and you can look those over. There's no such thing as any numbers on any exam you're going to take with us, but just look to see. And if they're in a hypermetabolic mode from seizing and going through tonic-clonic seizures, they're going to really chew through the drug. So be prepared for that. So the goals is to maintain and protect the patient, maintain their airway, their breathing, and their circulation until 911 or the emergency people get there. Administer the medications to stop the seizures, being aware that you're going to sedate the patient very well with that and prevent injury to the patient and to you guys too from the patient experiencing the seizure activity. Here's some suggested doses. Again, every patient's going to differ. I want you to read books and look at things to see how you should dose your patients. Let's talk about oversedation. We're going to want to maintain the airway here. So you see here the person's jaws being tilted up in the air, so a jaw tilt, so that the tongue moves away from the back of the throat. Or in a really well sedated patient, we can do a jaw thrust. And notice that looks like Larson's maneuver. Larson's maneuver and the jaw thrust are very, very similar. So in treatment for this, we're going to want to support the airway, make sure there's movement of air, make sure that you're checking their heart rate, blood pressure, and their pulse oximeter. And you can vocalize to the patient to wake up. I don't know that I would necessarily jump in and reverse the patient, but I would wait out the oversedation, especially if you've got more work to do. So I really want to see you titrate your drugs to the patient, any meds that you give them that sedate them. It's better to be able to add a little bit more than to go overboard and have to deal with that. So oversedation is a very rare emergency. And if you use the patient's first name, patients really respond to that. People like to hear their name, and it will wake them up out of a sleep. So when we've got a patient on the OR table or for sedation in the dental office, we'll say something like, "Michael, wake up. It's time to wake up. We're still working on your teeth, but you need to wake up," in a nice loud voice. So again, this is rare, and you've got to titrate your drugs, and you just hopefully will never see this medical emergency. Only in pretty drastic incidents, and I'm not saying that you won't use it, but would you use Narcan or flumazenil to reverse either the narcotic or the benzodiazepine? Narcan can give a very stark amount of pain to the patient if you've been titrating narcotic for them. So I usually let that bottle expire because I just carefully titrate the drugs. You know, if you've got an older patient, let's say you're treating a physical classification ASA2 patient, and it might be an 85-year-old who doesn't need a lot of sedation medication. If you want to use something like Narcan, you can dilute the Narcan other than making it into a 10 milliliter syringe where it makes 40 micrograms per milliliter, you can dilute it even further and give them a really light dose because they're going to have a stark reaction when you give them something like Narcan. But just know that these reversals are in your toolbox for if you're using narcotics or if you're using benzodiazepines. Let's talk about hypoglycemia. Glucose is the only fuel for the brain. We do not store glucose. It's not synthesized also in the brain. It's not stored or synthesized. So it constantly has to be brought by the bloodstream. It crosses without any carriers across the blood-brain barrier and goes straight to the neurons in the brain. So it is the fuel, and it's got to be brought there in huge quantities to keep that highly metabolic brain working. So hypoglycemia is a plasma glucose of less than or equal to 55 milligrams per deciliter of blood. Not milliliter, but deciliter, which is going to be a lot more blood. Normal fasting glucose for a person that's not diabetic or has any problems not taking any meds is generally at least 80, if not larger, milligrams per deciliter. So it's 80 to 110 is their fasting glucose. So 55 is really low, and you're going to see a lot of symptoms with that. And those symptoms are going to be really similar to the other symptoms that we've seen with nausea or with the vasovagal response. And those symptoms are, again, diaphoresis or sweating, jitteriness or nervousness, kind of like when you get hangry and you feel that. There's tachycardia because they've been dry. They haven't been getting any fluids, hopefully within 2 hours. So there's going to be a tachycardia. They may have tremor, the shakes, altered mental status, so lethargy, confusion, or agitation. And then the patient may go ahead and just throw up or just pass out on you. So if they've taken their oral hypoglycemic, like metformin, glipizide, or their insulin, or now with Ozempic and Wegovy, it can really affect their blood sugar. So again, first patient of the morning so that they can get back and eat. And if that means bumping another patient, unless it's an emergent patient, but you have to use your judgment to get them so that they can get their treatment and get back on their eating schedule so that their blood sugar can be maintained. So in order to treat hypoglycemia, we've got a tube of glucose. You can give them a sugary soda pop, or you could use even cake frosting, something that you could just go over to any grocery store and get, and it's just real high in sugar. Sucrose is a glucose and galactose. So they're going to get the glucose real quickly when they swallow or have that soda or their tube of real sugary substance. And if you can, when you do your IV stick for the patient, take and use some of the blood from the IV needle and use your point of care treatment for their blood sugar and record their blood sugar before you even start the case. So there's the icing, a sugary candy, a soda pop, and there's your point of care AccuCheck machine or blood sugar tasting machine. Something else that you will do if you've got an IV going, you'll have in your emergency drug kit dextrose 50, D50, and you would just take and clean off the little nipple on your 500 milliliter bag of IV fluid and inject that into the IV mix and open the IV so that they're quickly getting the sugar extremely rapidly through the blood. So we've got to get, in the goals of treatment, the glucose fuel to the patient quickly. Treat emesis if need be. So here's some treatment dosages and things to take care of the patient. All right, let's talk about asthma bronchospasm. And if you haven't ever used an inhaler, I want you to at least look at or think through how you're going to have your patient properly use their inhaler, because more than likely they're not using it properly. So I want you to know how to teach them, if it's a matter of doing it preoperatively, which is what I'm going to suggest, have them do it the right way, and we'll talk about that in just a bit. There's a lot of different aggravating factors that can make a patient start to have asthmatic effects, and they can be as a result of nervousness, vasovagal, low blood sugar, anxiety, nausea. All those things can precipitate asthma. So what's happening is that a rapid inflammatory response is occurring, and the patient is having such things as wheezing, coughing, chest tightness, and breathlessness, which is also called dyspnea, which dyspnea means difficulty breathing. So asthma has been likened to a fibrillation, not of the heart, but of the lungs, if you will. And the patient's air passages are just spasming closed. And so the patient is extremely stressed and air hungry. So the old adage, an ounce of prevention is worth more than a pound of cure, works well with the asthmatic patient so that they don't experience the asthma or bronchospasm. So when you're reviewing the patient's health history the day of surgery, make sure that when you tell them to come to the office is to bring their own inhaler with them. And if they've had trouble breathing a day or two before, it might be allergy season, they might be experiencing some pretty severe asthma, pretty stressful asthma for them, you might consider canceling the patient before they even come to the office, or unfortunately, while they're in the office. Better to do that than to have a really severe or any kind of an asthmatic episode occur in your office. So it just prevent them from having a problem. It's well worth more than a pound of cure. Again, the causes of asthma can be pollen, heavy exercise, or even light exercise, breathing cold air, dust, animal dander, mold that they're breathing, and certain chemical odors. Some people can't breathe certain dental material odors. Perfumes, lotions, and creams can cause that also, the scents that come off from them. So what we want to do is to discontinue the dental procedure immediately. You're not going to be doing it anyway if the patient's having that terrible sound of them being air hungry. And remember, if you sedate them, they're going to be even more vulnerable to a lot of problems. So calm the patient down, get the dental materials away from their mouth, get their inhaler and administer the puffs through their mouth, have them breathe it in. Hopefully they're not too awfully sedated. Get the small oxygen tank and the bag mask valve and help them breathe those vapors in. And you might have to treat them several times with their puffer or your puffer that's in your emergency kit. So you're going to want to puff it a couple times in their mouth and then just breathe it and hold the breath in so that the vapors are touching the lung. And one of the other drugs for bronchial asthma is Primatene Mist that you can buy over the counter, or if they're using an inhaled corticosteroid because of the inflammation that occurs with some patients that are asthmatic. So there's a picture of the albuterol inhaler and Primatene Mist that, as I said, you can purchase over the counter. I would get an inhaler of it, and unfortunately they're quite a bit more expensive than they used to be. They're probably over $60 now for one of those inhalers, and albuterol is expensive too. But you've got to have fresh, unexpired inhaler in your emergency drug kit in case they've used up their inhaler, forgot it, or whatever. If you want to, you can build it into the cost of what you're doing for their dental treatment. So I want to show you, as we talked about in the introduction of this part of the course, is how to properly administer the inhaler. So follow these steps. Don't alarm the patient, don't exasperate the problems, and make their breathing even worse. So you have the patient blow out as much air as they possibly can. I would not even have nitrous going. You've got to get them to blow the air out. And then you administer 2, 3, or 4 puffs in their mouth. Keep their mouth closed. Breathe in the air, either through their nose or through their mouth before you close it. And have them hold their breath for as absolutely long as possible. So you want to have a good seal with the inhaler. Close their mouth. Give them several puffs. Inhale the vapors and hold it for as long as they can so that the vapors of the albuterol, which is a beta-2 stimulator, is going to relax the bronchioles. It's going to relax the alveolar mucosa so that the patient can start breathing again. And if you have to, have them then exhale, do a couple more puffs, and make sure that you write these in the chart, the time that you did it, how many puffs that you administered. If you did 2 puffs or 4 puffs twice, make sure that you document that. So again, albuterol is a beta-2 agonist. So we want to assist the patient in eliminating those bronchial and those small airway spasms that they're having so that they can resume their breathing. If you can have them start to breathe normally again and you've got the patient calm, I would go ahead and keep working on them. You might not want to use nitrous or a lower dose of it, but make sure that you supplement them with some oxygen. So there's your dose for albuterol and for your Primatene Mist. And again, these are only suggested doses. Read your labels and your package inserts for any of the drugs we've talked about. For our last dental office medical emergency, we've got respiratory depression, and it has many different causes, as did hypertension. A lot of different causes that you have to make a diagnosis for so you know how to treat it. So respiratory depression has a lot of different causes too. And some of those causes are the over-narcotized patient, the over-sedated patient, some person with partial airway obstruction, could be also complete airway obstruction, but that's a whole nother emergency. So we're worried more about partial airway obstruction here. Poor patient positioning. We haven't talked about it much at all in this course, but you should have your patient in what is called the sniffing position. So a pillow underneath their occiput in the back of their head tilted up in the air and their head forward. That is the most ideal to get the tongue away from the back of the throat and to facilitate breathing. If they've got bronchiolar constriction, this is going to be a case for Primatene Mist. If they've got an upper respiratory infection, I don't treat a patient that day if they're coughing and wheezing and they've got yellow phlegm and they're running a fever or whatever. Children that are experiencing this, the standard of care is to wait 14 days after the end of the upper respiratory infection. If they're having a severe dental emergency, you may have to treat it, but just be prepared that probably they're going to cough on you, but they're going to have trouble with their airway. Somebody with a chronic cough can have respiratory depression. And then when you add sedation to it, again, it changes everything. Your COPD patient, your emphysemic patient, your smokers, your patients that are substance abuse for opioids, and your alcohol abuser are going to make for really tough respiratory depression. So the treatments are going to vary depending on what it is that you're treating after you made your respiratory depression diagnosis. For an over-narcotized patient, really go slow and use an adjuvant other than a narcotic to get them into a state where they're going to be comfortable. This is where Toradol or Caldolor or Oframev can be used. So we can use IV ibuprofen, IV Toradol or something, or IV Tylenol, acetaminophen, to really help the patient. These drugs are not cheap, but it should be built into the patient's cost for that treatment. So if they're over-narcotized, again, you've got to titrate your dose. Again, oversedation, number 2, is rare. Just tell the patient, use their name, wake them up. Be really careful with your titration of doses. Stay within the parameters of your anesthesia permit. Do not go over, or you could be in big trouble, not only with treating the patient, or if the patient runs into trouble, you could be into trouble with your dental board. If they've got partial airway obstruction, the best thing that they can do is to have the patient remove it themselves with a good cough, or if you have to, you can intervene, but use the patient to help wake up from their partial airway obstruction. Again, positioning is critical. Always have the patient in that sniffing position. Reposition them, get their head up straight, get their back straight. You can bring the back of the chair up a little bit and just position their head and neck that are amenable to breathing. And if it's bronchiolar constriction, you can use albuterol again, or Primatene Mist like what we just talked about, or their corticosteroid inhaler. If they've got an upper respiratory infection, again, a lot of times I hate to do it, but we'll cancel the case before you even start. You've got a really reactive airway, and you could be in big trouble if you see those patients. If they develop an emergency, it's going to be really hard to treat them with that reactive airway, and they could obstruct, and you could really run into problems with their SAT and their breathing. So make the dental visit brief and just move it on. Use local anesthetic. I wouldn't even use sedation. For your chronic cough patient, you can have them use whatever they use to stop the cough. What I do with patients that have chronic cough is before we even start, when I'm first looking at the patient preoperatively, and again, our forms sheet that you can download on sedationconsult.com, the forms section is if they are having trouble breathing, it's a chronic cougher, I will have them go ahead and do some cough and deep breaths. And when I talk about a cough, I'm going to do one here, but I don't want a patient going something like that. I want them to take a deep breath in, and I want them to do a gut-wrenching cough, something like a something on that order. It will open any of those collapsed alveoli, really open them up. You won't hear any wheezing. Hopefully that's going to stop the cough for a long while. So have them do that preoperatively. Your COPD emphysema patient might want to visit their physician first to optimize their breathing prior to your dental treatment, and just consider very light sedation so that they're doing their own breathing and you're not at all hindering their breathing, their own spontaneous breathing. Smokers, in order for them to stop and not cough, they have to go at least 8 weeks or greater to clear their lungs. So hopefully they have abstained for at least 24 hours prior to your dental visit. So that is one of the things that you would put on your to-do list when you're talking to the patient. And of course, patients don't always tell us the truth, but we document and we ask them if they've had any smoking before they started. A person that is an opioid or other substance abuse, and this could be cocaine, methamphetamine, amphetamine, any of the really potent opioids, heroin, this sort of thing, fentanyl, they're just not a candidate, and you would be really silly to go ahead and sedate them or to do dental treatment with them. An alcohol abuser, hopefully they've maintained their NPO status. You saw the fasting guidelines for NPO, but they're going to really chew up the drug. If the alcohol abuse occurred just preoperatively, I would go ahead and cancel the case. So that is all we have with this lecture. Thank you for attending the lecture.